A central venous line is defined as an intravenous cannula whose tip terminates in one of the large vessels that drains directly to or from the right side of the heart. This module would present the core theoretical and practical knowledge and demonstrate the basic techniques required to safely insert and maintain central lines in intensive care patients. In this video, we will review the indications, contraindications, and insertion site-specific considerations for the insertion of central venous lines. This is core knowledge for intensive care practitioners. The following are the main indications for the insertion of a central venous line: the need to administer vasoactive or irritant drugs, frequent venous blood sampling, vascular access in patients whom peripheral vascular access is difficult, to facilitate the insertion of a pulmonary artery catheter or temporary pacing wire by way of an introducer sheath, for the delivery of extracorporeal therapies such as renal replacement therapy or plasmapheresis, and for long-term therapies such as the delivery of parenteral nutrition. Central venous access is also required for veno-venous or veno-arterial extracorporeal membrane oxygenation. However, this will not be further discussed in this module. Contraindications to CVL placement. Contraindications are generally relative and site-specific. In the critically ill, the presence of a relative contraindication usually points towards a preferred site of insertion, rather than negating the need for central venous access altogether. The main contraindications are coagulopathy, insertion site, or vascular abnormality. Coagulopathy. UK guidelines advise caution when the platelet count is below 50 times 10 to the 3 and the INR greater than 1.5 or the APTT greater than 50. However, evidence-based guidelines are lacking. There are multiple small studies which fail to demonstrate a link between coagulopathy and bleeding complications following CVL insertion. A review of the literature up to 2010, published in Critical Care Medicine, indicates that CVL insertion at either the internal jugular or femoral veins using ultrasound does not require any correction of coagulopathy or platelet count. The authors concluded by saying that rates of hemorrhage appear to be closely related to the level of experience of the physician rather than the defects of hemostasis. This has further been supported by case series data in 2013 in Critical Care Medicine, which found no bleeding complications in 41 patients with severe clotting abnormalities, or 76 patients with moderate coagulopathy. The next contraindication is local insertion site abnormality, for example, local infection or significant trauma. Placing a femoral line distal to a vein damaged due to pelvic trauma should be avoided. Similarly, avoid insertion through clearly infected skin or soft tissue. The final contraindication would be underlying vascular abnormality, such as pre-existing venous thrombosis. Site-specific considerations. Central venous lines are inserted in one of 6 locations: either the left or right subclavian veins, femoral veins, or internal jugular veins. Certain sites have relative contraindications attached, again, however, usually without accompanying quality data. Firstly, for the subclavian vein, most operators will avoid this site in coagulopathy due to the inability to observe or compress emergent bleeding. Severe unilateral lung pathology usually steers clinicians away from the normal side to minimize the effects of a pneumothorax should that occur. Studies fail to demonstrate an increase in pneumothorax with the subclavian site. For the internal jugular vein, as described, coagulopathy is not a contraindication. However, the persistence of ongoing soiling from tracheostomy secretions provides a theoretically increased infective risk at this site for long-term patients. For the femoral veins, this route is less favoured in the presence of underlying abdominal or pelvic trauma, given the underlying risk of vascular disruption, or in those with an elevated body mass index, given the increased infective risk. This concludes our brief introduction to the indications and contraindications to central venous lines and their specific sites. The next section will cover techniques, anatomy, and a more detailed description of the various sites for central venous line insertion. We will also look at the use of ultrasound to guide the insertion of venous lines and examine the complications that can arise in the ICU following this procedure.